Welcome back to the Deep Dive. Today we are doing something that I frankly love doing. We are going back to the source code. We're stripping away all the noise and cracking open one of the absolute titans of medical literature.
We certainly are. We're talking about Baily and Love's Short Practice of Surgery.
Specifically, the 28th edition.
It really is the Bible for surgical trainees. I mean, if you walk into a surgeon's office and they don't have a battered, dog-eared copy of Baily and Love on the shelf, you might want to, check their credentials.
We're zooming in, and I mean really focusing on one chapter in particular, chapter 60, the thorax. Now, I want to set the stage here because the chest, it's a black box.
It really is.
You've got the heart, the lungs, the great vessels all pressurized inside this cage of bone. It feels incredibly high stakes.
Because it is high stakes.
Right.
Absolutely. The margin for error in thorax is, well, it's effectively zero. You mess up the pressure dynamics, you could stop the heart, you clip the wrong vessel.
It's a catastrophe.
It is. It's a region of the body that just demands absolute respect.
So our mission today is very specific. We're not just going to read the chapter to you. That would be boring and honestly a waste of your time. Our mission is to interpret, to simplify, and to provide what we're calling anchors for the really critical concepts in this chapter.
Think of this as a ready reckoner or, a revision tool. If you're a medical student or a surgical trainee prepping for exams, this is for you. We want to give you the hooks to hang all the details on.
But, and this is important, disclaimer time, we are covering the aha moments, the core logic. We absolutely cannot replace the textbook.
No way.
Baily and Love is famous for its diagrams. I mean, the CT scans of empyema, the maps of the lymph node stations. You need to see those.
You really do. Consider this the primer that makes reading the actual chapter 10 times easier. We're the map.
The book is the territory, so please go read chapter 60 after this. Okay, here's the roadmap for this deep dive. We're going to start with the lay of the land, the anatomy and physiology that actually matters to a surgeon. Then we'll move to the gatekeeper, how we decide who is actually fit enough to survive thoracic surgery.
And then we'll get into the physics of the pleura, the scary world of lung cancer, and finally that really busy box that is the mediastinum.
You ready?
Let's crack the chest.
All right, section 1, anatomy and physiology. The text kicks off right at the beginning with embryology. It says the lungs start as an outpouching of the foregut. Now, usually my eyes glaze over when I read about embryology. Does it actually matter for the surgeon on the ground?
It does. It really does. It matters because it explains the variations we see on the table. The lung starts as this little bud, and then it splits. And that splitting process, that defines the lobes.
Okay.
But the text makes a really crucial point. While the lobar arrangement is fairly constant, the fissures, the deep cracks that separate the lobes, they are often incomplete.
And why is an incomplete fissure a problem?
Well, let's say you're trying to remove just one lobolobectomy. If that fissure isn't complete, you can't just bluntly dissect it. You have to physically cut through lung tissue to separate them.
Which means more bleeding, more air leaks.
Exactly, more complications. So knowing the embryology just reminds you that the textbook lung isn't always what you're going to find inside the patient.
Okay, so let's talk about that textbook arrangement. The right lung versus the left lung. They're siblings, but they are definitely not identical twins.
No, not at all. They have very different personalities. The right lung is the big brother. It's larger, it's heavier, it takes up more volume. It's got 3 lobes, the upper, the middle, and the lower.
And because it has 3 lobes, it needs 2 fissures to separate them.
Correct. The oblique and the horizontal fissures.
And the left lung.
The left lung is smaller. It only has 2 lobes.
Yeah.
The upper and the lower. And therefore only 1 fissure, the oblique.
I always use the heart anchor for this. I mean, it makes sense. The heart sits primarily on the left, right?
It does.
It takes up this massive amount of real estate in the left side of the chest. So the left lung basically had to, sacrifice its middle lobe to make room?
That is precisely the logic. But here's the cool bit, the nuance. The left lung didn't lose that middle lobe entirely. It kept a remnant. A little piece we call the lingula.
Which translates to little drum.
Exactly. It's this tongue-like projection of the left upper lobe that sort of wraps around the heart. And anatomically, and more importantly, surgically, the lingula corresponds to the middle lobe on the right.
So pneumonia in the lingula would look and act just like pneumonia in the right middle lobe.
Precisely.
Okay, let's move down the pipes. The bronchial tree. Baily and Love makes a very, very specific point about the geometry of the right main bronchus versus the left. This feels like one of those facts that actually saves lives.
Oh, it does. So the trachea splits at a point called the carina, And the anatomy there dictates that the right main bronchus is shorter, it's wider, and it's much more vertical than the left.
I love the highway metaphor for this. Imagine the trachea is a major interstate highway. The right bronchus is like a big, wide, gentle off-ramp that you can just sort of slide onto without even turning the wheel.
Whereas the left bronchus...
The left is a sharp, hard 90-degree turn. You really have to crank the wheel to get down that one.
Which brings us to the clinical consequence. And this is practically a law of physics in the emergency room.
If a child inhales a peanut or a tooth or a Lego brick, where does it go?
Down the path of least resistance?
Always.
It's going down the right side.
Almost exclusively. Gravity and geometry just funnel it straight down the right main bronchus. So if a kid comes in choking or an adult comes in with aspiration pneumonia after passing out, your first instinct must be to check the right lung.
Right. Now, what about the drainage system, lymphatics? The text mentions stations and zones, which, to the uninitiated, sounds a bit like a subway map. It essentially is. It's a transit map for cancer cells. The lymphatic system follows the bronchi back towards the center of the chest, towards the heart. And surgeons and oncologists, we've divided these lymph nodes into numbered stations to standardize our language.
So everyone's talking about the same thing.
Exactly. For example, station 10 represents the hilar nodes right at the root where the bronchus enters the lung. Station 7 is the subcarinal node right under the crotch where the trachea splits.
But why do we care about the specific number? Why can't we just say, oh, the lymph nodes are involved?
Because in thoracic oncology, geography is destiny. The station dictates the end stage in the T&M cancer classification. If cancer is in the hilar nodes, say station 10, that's N1 disease.
Which is local.
Right, it's local. We can usually operate on that. We can often cure it.
But if it travels further up the map?
If it jumps to the mediastinal nodes like station 7 under the carina or station 4 along the trachea, that becomes N2 disease. And that implies the cancer has left the building, it's left the lung, and is starting to access the systemic circulation.
It changes the whole game.
It changes the stage entirely. N2 disease often means surgery is off the table, at least initially. Or it means we need to give chemotherapy first to try and shrink it back.
So the stations tell you how far the enemy has advanced. N1 is maybe the front porch.
And N2 is inside the house.
That's a perfect way to visualize it.
It is.
Before we leave anatomy, let's just touch on the mechanics of breathing. It's not just the lungs expand. The text describes two really distinct mechanical actions working together.
That's right. You have the walls and you have the floor. The intercostal muscles between the ribs provide what we call the bucket handle movement.
Okay, walk us through the bucket handle.
Imagine a bucket with the handle resting down against its side. When you lift the handle, it moves out and up.
Right.
That is exactly what your ribs do. They swing out and up, and that increases the transverse diameter of the chest. It makes the chest wider.
And the floor.
The diaphragm, that acts like a piston. When it contracts, it flattens and it moves down. This increases the vertical height of the chest cavity. So, simultaneously, your chest is getting wider from the bucket handle action and taller from the piston action.
Which create a huge negative pressure.
A massive vacuum, and air just rushes in to fill the void.
Okay, let's do a quick check-in question for you listening, based on that geometry we just discussed. If a child inhales a small plastic bead, which bronchus is it likely lodged in, and why? Just take a second to think about that highway.
And the answer is the right bronchus. Why? Because it is wider, shorter, and more vertical. It's the highway off-ramp.
Let's move on. Section 2, the gatekeeper. This is the assessment of fitness for surgery. This section really struck me because it highlights a paradox, right? You have a patient with lung cancer. They need surgery to survive the cancer.
Mm-hmm.
But the surgery itself involves removing a piece of the very organ they need to breathe.
It is the central dilemma of our field. Can we cure the disease without crippling the patient? And Baily and Love is crystal clear here. You cannot just operate because the tumor is removable. You have to operate only if the patient is durable.
So how do you measure that?
The British Thoracic Society, the BTS, recommends what they call a tripartite risk assessment.
3 specific hurdles. What are they?
Okay, hurdle 1, operative mortality. Will they survive the anesthesia and the trauma of the surgery itself? Hurdle 2, perioperative cardiac event. Is the stress of the surgery going to cause a heart attack? And hurdle 3, which is a big one, postoperative dyspnea. Will they be left breathless for the rest of their life?
Let's break those down. For mortality, the text brings up something called the Thoracic score.
This is the industry standard. It's a risk model. It takes 9 variables, things like age, sex, their comorbidity score, their ASA grade, how fit they are generally, whether they have cancer, and so on. You plug these into the model, and it spits out a percentage risk of death. It provides objectivity. It stops a surgeon from just, eyeballing a patient and saying, oh, he looks fit enough.
And the cardiac risk, that seems pretty crucial.
It is. Thoracic surgery places a unique stress on the right side of the heart because you are clamping the pulmonary vessels. The text has a very strict rule here. Surgery should generally be avoided within 30 days of a myocardial infarction.
A heart attack.
Yes. If they've had a recent heart attack, you just have to wait. The heart is too irritable, too unstable.
Okay, now let's get into the weeds of the lung function tests. The numbers game. We see these acronyms all the time. FEV1, FVC, DLCO. I won't anchor these so they're not just, alphabet soup. Let's start with FEV1.
Okay. FEV1 stands for forced expiratory volume in 1 second. Imagine you take the deepest breath you can possibly take and then you blast it out as hard and as fast as you can. FEV1 is the volume of air that leaves your lips in that very first second.
So what is it fundamentally measuring?
Speed. It's measuring the caliber of your airways. If your bronchial tubes are narrowed like in asthma or smoker's lung, COPD, you can't get the air out fast. So that volume, the FEV1, drops.
And FEC?
That's the forced vital capacity. That's the total amount of air you can squeeze out from a full breath until you are completely empty. So FVC is measuring the size of the tank.
So FEV1 is the flow rate, FVC is the tank size. This brings us to that crucial distinction in the text between obstructive and restrictive lung disease. Baily and Love has a great table on this. How do we tell them apart using these numbers?
So in obstructive disease, think COPD, emphysema, asthma. The problem is getting the air out. The tubes are floppy or they're tight.
Okay.
So the FEV1, the speed, absolutely crashes.
Okay.
But the FVC, the tank size, that might be normal. Therefore, the ratio of FEV1 to FVC drops, usually below 70%. That low ratio is the absolute hallmark of obstruction.
And restrictive?
For restrictive, think fibrosis. The lungs are stiff, like trying to blow up a leather balloon. Or maybe the chest wall is rigid from scoliosis. The tank itself is small, so both the FEV1 and the FVC are low.
But the ratio?
Because they're both low, the ratio stays normal.
That's the key anchor then. Low ratio equals obstruction. Normal ratio with low volumes equals restriction. But there's a third test mentioned, DLCO. The transfer factor. What is this adding to the picture?
Spirometry only tells you about the plumbing, the air movement. It doesn't tell you if oxygen is actually getting into the blood. DLCO measures the gas exchange at the microscopic level.
The actual business end of the lung.
Right. In emphysema, the air sacs, the alveoli, are physically destroyed, so you might be able to move air okay, but there's no surface area for the oxygen to cross over. If the DLCO is low, that's a huge red flag. It means the lung tissue that's left behind isn't working very well.
Which leads directly to the split function calculation.
This fascinated me.
It's basically doing math to predict someone's future quality of life.
We have to. We absolutely have to predict the future. We know the lung has roughly 19 segments. The right lung has 10, the left has 9. So if I plan to remove, say, the left upper lobe, I know I'm taking out roughly 5 of those 19 segments.
So you're removing what? About 25% of their total lung capacity?
Exactly. So I take their current FEV1, their pre-op value, and I multiply it by the percentage of lung I'm leaving behind. This gives me what we call the predicted post-operative FEV1.
Okay, let's try a fictional case study to make this stick. Listeners, try to visualize this patient. Let's meet Mr. Smith. He's 70 years old, a heavy smoker for 40 years. He's got a resectable tumor in his left upper lobe. He wants it out. His pre-op FEV1 is 2.0 liters. Is he fit for surgery?
Okay, so let's work through Mr. Smith. First, we check the heart. We talked about that. If that's clear, we do the math. We're taking out the left upper lobe. That's 5 segments out of 19. That's roughly 25%, as you said. So we expect he's going to lose about 25% of his function.
So 25% of 2.0 liters is 0.5 liters. He loses that much.
Right. So his predicted post-op FEV1 will be roughly 1.5 liters. Now, we look at the guidelines. Generally, if that predicted post-op value is greater than 40% of what's expected for his age and height, he's probably safe.
Well, what if it's lower?
If it drops below that 30-40% threshold, he is at very high risk of becoming a respiratory cripple. He might not be able to walk to the bathroom without gasping for air.
And in that case, you have to say no to the operation.
Or we have to look for a smaller operation, maybe a wedge resection instead of a full lobectomy. Or we send him for focused radiation instead. It's all about balancing survival with livability.
Right. Section 3. The pleura. Vacuum seals and fluids. This is where physics meets biology in a really, really elegant way.
The pleura is just beautiful engineering. It's 2 layers of membrane, the parietal on the chest wall, the visceral on the lung itself, and between them is this tiny microscopic space with just a drop of fluid.
The text uses an implicit analogy here that I absolutely love. It's like 2 glass slides with a drop of water between them.
It's the perfect metaphor. If you take 2 wet glass slides, you can slide them back and forth with almost no friction. That's the lubrication allowing the lung to move while you breathe, but then try and pull them apart.
Impossible.
You can't lift that top slide off.
That's the surface tension.
That is the negative pressure. It's what keeps the lungs inflated and basically stuck against the chest wall.
The text mentions startling forces when talking about the fluid balance.
Right. It's a constant tug of war. Hydrostatic pressure pushes fluid into the space. Oncotic pressure pulls it out. In a healthy person, the pull is slightly stronger. So the visceral pleura is always absorbing fluid, keeping the space dry.
And when that balance breaks,
Due to heart failure or an infection or cancer, fluid accumulates, and that's a pleural effusion.
but what happens when it's not fluid? What happens when air gets in? The pneumothorax. The text divides this into primary and secondary, and this distinction seems absolutely vital for how you manage them.
It is. It's everything. A primary spontaneous pneumothorax, or PSP, is a very specific phenotype. It's the tall, thin young man. He's maybe 20 years old, maybe smokes a bit. He's just walking down the street and suddenly feels a pop in his chest. A subpleural bleb, a tiny little blister on the very top of the lung. The lung collapses a bit, but his underlying lung tissue is totally healthy. He has reserve. He'll probably be just fine.
And secondary.
Secondary means secondary to an underlying disease. This is the 70-year-old with COPD or emphysema or fibrosis. His lungs are already, shot. If he pops a bleb, even a small collapse can be catastrophic because he has zero reserve. These patients can die from a relatively small pneumothorax.
And then there's the monster. Kenshin pneumothorax. This is the Hollywood emergency room moment, right?
It is a true physiological disaster. It's a one-way valve mechanism. Every time the patient breathes in, air gets sucked into the pleural space through a hole in the lung, but when they breathe out, a little flap of tissue closes and the air is trapped.
So the pressure just builds and builds with every single breath.
Exactly. It pushes the lung down until it's completely collapsed. Then it pushes the mediastinum, the heart, and the trachea over to the opposite side.
So it creates a kink in the plumbing.
That is the killer. It's not the collapsed lung. It's the fact that it kinks the superior and inferior vena cava. Blood cannot get back to the heart. Cardiac output drops to 0. The patient goes into shock and dies. It's a circulation problem, not a breathing problem.
So how do we manage these? Let's go back to the BTS guidelines. The text has a flowchart.
It all comes down to 2 simple variables, size and symptoms. Is the rim of air between the lung and the chest wall larger than 2 centimeters? And is the patient breathless?
If it's small and they feel fine.
You observe. You can send them home with good advice or watch them overnight. The body will just absorb the air on its own.
And if it's a primary, the young, healthy guy, and it's large and he's symptomatic.
The guideline says aspirate first. Don't go cutting a hole just yet. Put a small cannula in, suck the air out with a big syringe. It works about 60 to 70% of the time.
But if it's a secondary, the older, sick patient.
You don't mess around with aspiration. It rarely works, and they are way too fragile to be waiting around. You put a chest drain in, immediately they need a proper tube.
Speaking of tubes, let's talk about the chest drain, or tube thoracostomy. There is a sacred zone for putting this in, the triangle of safety.
You have to memorize this. The boundaries are critical to avoid hitting very dangerous structures. The anterior border is the lateral edge of the pectoralis major muscle.
The big chest muscle.
Right. The posterior border is the anterior edge of the latissimus dorsi.
The big back muscle.
And the inferior border is the level of the nipple, which corresponds to the 5th intercostal space.
So high up in the armpit, basically, above the nipple line, between the pec and the lap.
Correct. And there is a pro tip in the text about the insertion technique itself. When you go in, you must go over the top of the lower rib.
Why over the rib?
Because the neurovascular bundle, the vein, the artery, and the nerve runs in a little groove on the underside of the rib. If you slide your instrument along the bottom of a rib, you are going to slice that intercostal artery or the nerve. It can cause massive hemorrhage or permanent nerve pain. Always ride the superior border of the rib.
That is a crucial anchor. Now let's switch from air to fluid. pleural effusions, and the dreaded empyema pus in the chest.
Empyema usually follows a nasty pneumonia. The bacteria spill out of the lung into the pleural space. And Baily and Love describes 3 stages, and this isn't just academic. The stage dictates the surgery.
Okay, stage 1.
The exudative phase. The fluid is thin, it's watery pus, it flows easily. You can usually treat this with strong antibiotics and a simple chest drain.
And stage 2.
The fibrinopurulent phase. The fluid starts to get thick. Fibrin, the protein involved in clotting, starts to form these webs and pockets. We call them loculations. It turns the whole space into a honeycomb.
So a simple 2 won't work anymore.
Right, because it can only drain the one little pocket it's sitting in. You usually need VTS surgery, keyhole surgery, to go in, break up all those pockets, and wash everything out.
And stage 3, the final stage.
The organizing phase. The body tries to wall off the infection. It forms this thick, hard, fibrous rind cortex all around the lung. It's like the peel on an orange. And this rind physically traps the lung so it cannot expand. We call this trapped lung.
At this point, just draining it is completely useless.
Totally useless. You have to do a decortication. You have to surgically go in and peel that thick rind off the surface of the lung to let it pop back up. It's a bloody, difficult operation, often requiring a full open thoracotomy. The lesson is simple. Treat empyema early so you never get to stage 3.
Let's do a quick check-in for the listeners. Close your eyes for a second. Visualize that triangle of safety. What is the anterior border?
It's the lateral edge of pectoralis major. If you got that, you're safe to proceed.
Okay, section 4, disorders of the airway. We're talking hemoptysis, coughing up blood.
Which is always a red flag. Always. In a textbook, the list of causes is a mile long. In reality, in the clinic, you're thinking 3 things. Cancer, bronchiectasis, or infection like TB or an aspergilloma, you have to investigate. Chest x-ray and a CT scan are mandatory.
But eventually, you've got to look inside. Bronchoscopy. The text makes a clear distinction between flexible and rigid bronchoscopy. Most people have probably seen the flexible one. It looks like a long black noodle with a camera.
The flexible scope is the workhorse. It's done under sedation, usually goes down the nose. It's great for looking around corners and taking small biopsies. But the thoracic surgeon's secret weapon is the rigid bronchoscope.
A metal pipe.
It is literally a hollow metal tube connected to lights and a ventilation port. You do this under a full general anesthetic.
Why use such a primitive-looking tool?
Because it offers absolute control. If a patient is bleeding massively into their airway, a flexible scope just gets covered in blood. You can't see anything, you can't suction effectively. The rigid scope protects the airway. You can ventilate the patient through it. You can stick large suction catheters down it.
And for foreign bodies.
Right. If you need to pull out that Lego brick we talked about, you can't pull it through a tiny flexible scope. You need the rigid scope and a big grabber to get it out. It's also used for coring out tumors or placing stents to keep the airway open.
Speaking of foreign bodies, there's a really creepy detail in the text about the silent interval.
It's a classic trap for the unwary. A child chokes on something, they cough, they might turn a bit blue. Then the object settles down into the bronchus, the reflexes stop. They seem fine.
That's the silent interval.
Yes. Parents think, oh, phew, he coughed it up. But the object is still there. Weeks, maybe months later, the kid comes in with a wheeze that won't go away, or a pneumonia that keeps coming back in the exact same spot. You have to have a high index of suspicion.
Moving on. Section 5. Neoplasms. Lung cancer. This is the big killer. The text is blunt. It's the leading cause of cancer death, and 85 to 95% of it is related to smoking.
It's a preventable epidemic, really.
Yeah.
But once a patient has it, the classification is the first and most important fork in the road.
We split them into 2 main camps, small cell and non-small cell. Why is this distinction so binary?
Because their behavior is radically different. Small cell lung cancer, SCLC, often called oat cell, is incredibly aggressive. It is considered a systemic disease from the moment of diagnosis.
Meaning it's already everywhere.
Basically, yes. By the time you find it, it has likely already spread microscopically. Therefore, surgery is almost never the answer. You treat it systemically with chemotherapy and radiation.
And non-small cell, NSCLC.
That's the surgical group. This includes squamous cell, adenocarcinoma, and large cell. Adenocarcinoma has actually overtaken squamous as the most common type, particularly in women and, interestingly, in non-smokers.
And they show up to different places.
They tend to. Adenocarcinoma tends to be peripheral out on the edges of the lung. Squamous tends to be more central, near the main bronchus.
Let's talk symptoms. We all know about cough and weight loss. But there's a specific syndrome mentioned that is pure exam gold and a fascinating anatomical lesson. the Pancoast tumor?
A Pancoast tumor is defined entirely by its location, the apex, the very top of the lung, right up under the collarbone. And because it sits there, it tends to ignore the lung and instead invades the structures above it.
So it grows up, not down.
Exactly. It grows into the brachial plexus nerves, which causes severe shoulder and arm pain, and it hits the sympathetic nerve chain running along the spine.
And damaging that sympathetic chain causes Horner's syndrome. I always struggle to remember the signs of that.
Use the mnemonic MAP. Just remember, MAP. M is for meiosis. The pupil on that side is constricted. It's tiny. A is for anhidrosis. That side of the face is dry, doesn't sweat. And P is for ketosis. The eyelid on that side droops.
MAP, meiosis, anhidrosis, aposis.
If a patient walks into your clinic with a droopy eyelid and severe arm pain, do not send them to a neurologist. Get a scan of the apex of their lung.
Let's talk about the workup. We know tissue is the issue. You need a biopsy. The text highlights a technology that seems to have changed everything. EBUSIS, endobronchial ultrasound.
Oh, it revolutionized staging. Absolutely. Before EBS, if we wanted to sample those lymph nodes in the mediastinum, those N2 nodes we talked about, we had to make an incision in the neck. It's an operation called a mediastinoscopy. It was invasive.
But EBS isn't.
No. EBS is a bronchoscope with a tiny ultrasound chip on the tip. You go down the windpipe, press the scope against the wall, and the ultrasound lets you see the lymph node on the other side. You then extend a tiny needle through the bronchial wall, and you suck up some cells. No skin incision, incredibly high accuracy.
That's incredible. So if we decide to operate, what are the options? The menu seems to be shrinking in a good way.
It is. The smallest option is a wedge resection, literally just taking a bite or a wedge out of the lung. We used to only do this for biopsies, but now for very small tumors or for frail patients with poor lung function, it's a valid cancer operation.
And the gold standard.
The lobectomy, taking the entire anatomical lobe along with its draining lymph nodes. This is what we aim for most cancers.
And the biggest operation.
Pneumonectomy, taking the entire lung, right or left.
The text seems very, very wary of this one.
It is a highly morbid operation. The mortality risk is 5 to 8%, which is massive. And living with one lung is very hard on the heart. It strains the right ventricle. We really try to avoid this at all costs.
And there's a clever technique mentioned to avoid it called a sleeve resection.
Yeah.
I love the engineering of this.
It is beautiful, elegant surgery. Imagine a tumor is sitting in the main bronchus, blocking off the upper lobe. In the old days, you'd have to take the whole lung out because the main pipe is blocked.
Right.
In a sleeve resection, you cut out the segment of the airway that contains the tumor like cutting a bad section out of a garden hose, and then you sew the two healthy ends back together. You remove the tumor, but you save the healthy lower lobe.
You preserve all that lung function.
Which is absolute gold for the patient's quality of life.
And of course, the whole approach to getting in has changed. We aren't cracking ribs open as much anymore.
It's not at all. VTS, video-assisted thoracoscopic surgery, and RX robot-assisted are the standard of care now. Small keyhole incisions, cameras, robot arms. The patient recovers in days, not weeks, compared to the old rib-spreading thoracotomy, which was just incredibly painful.
Okay, section 6, the mediastinum, the space between the lungs.
The busy box. It's got the heart, the great vessels, the esophagus, the trachea, the thymus gland, all the lymph nodes. It is crowded in there.
The text divides it into compartments to help with diagnosis. If you see a mass in the anterior mediastinum, that's the space in front of the heart, there's a very specific list of suspects.
It's the famous 4 T's. If you see a mass there on a CT scan, it is almost certainly one of these 4 things. Number 1, a thymoma. Number 2, a teratoma, which is a germ cell tumor. Number 3, thyroid, a goiter growing down from the neck. And number 4, terrible lymphoma.
Let's do a quick case study here to connect the dots. A 30-year-old woman comes to your clinic. She's complaining of double vision and her eyelids are drooping, especially later in the day. She just feels generally weak. You get a chest CT, and it shows a mass in her anterior mediastinum.
This is a classic board question, but also a very real-life presentation. The muscle weakness, the fluctuating droopy eyelids, that screams myasthenia gravis. And myasthenia gravis has a very strong, well-known link to the thymus gland.
Oh, the mass is a thymoma.
Almost certainly. About 10–15% of patients with myasthenia have a thymoma, a tumor of the thymus. And conversely, a large percentage of patients with a thymoma will develop myasthenia.
So what's the fix?
You take the thymus gland out.
Mm-hmm.
At thymectomy, we often do this robotically now through small incisions. It treats the tumor, and in many, many cases, it significantly improves or even cures the myasthenia gravis.
And what about the posterior mediastinum, the back of the box?
That area is right up against the spine, so you should be thinking neural tissue. The masses we find back there are usually neurogenic tumors, things like schwannomas or neuroblastomas growing from the nerve roots or the sympathetic chain.
Got it. Section 7. Other conditions and trauma. Just a few quick hits to finish up. Bronchiectasis.
This is a condition of chronic, permanent dilation of the airways. They become boggy, scarred, and they just pool mucus and pus. These patients cough up cups of purulent sputum every single day.
Is that a surgical problem?
Rarely now. We mostly treat it medically. But if the disease is localized to one completely destroyed lobe, a lobectomy can be curative and stop that cycle of chronic infection.
Lung abscess.
A cavity in the lung filled with pus. The rule here is simple. Antibiotics and posture. Postural drainage. You physically tip the patient in different positions so that gravity helps them cough all that pus up and out. And crucially, you almost never operate on an acute lung abscess.
Why not? Why not just cut it out?
It is incredibly dangerous. An abscess is a bag of liquid pus. If you try to cut it out, you risk rupturing it. If that pus floods into the airway, it spills over into the healthy lung, you can literally drown the patient in their own pus.
Wow.
So we rely on drains or long courses of antibiotics.
And finally, trauma.
The vast, vast majority of chest trauma, rib fractures, lung contusions, small pneumothoraces is managed conservatively. Good pain control and a simple chest drain will handle 85% of cases.
But sometimes you need the clamshell.
The emergency thoracotomy. This is the last resort, the Hail Mary. If a patient comes in with a penetrating wound to the heart, or they are bleeding to death into their chest, you make a massive incision across the front of the chest like, opening a clam to get immediate access to the heart and great vessels.
It's heroic, desperate stuff.
It is. You clamp the aorta to save blood for the brain, and you try and sew up the hole in the heart.
Okay, we have covered a massive amount of ground. From embryology to clamshelling the chest. Let's bring it home to the outro.
All right, let's recap the anchors. These are the absolute key takeaways you need to lock in from this chapter.
Anchor number 1. The right main bronchus is the highway off-ramp. That is where the foreign bodies go.
Anchor number 2. The triangle of safety for chest drains. Latissimus dorsi, pectoralis major, nipple line, and always, always go over the rib.
Anchor number 3. Horner syndrome. Remember, MAP meiosis, anagrosis. Ptosis points directly to a Pancoast tumor at the apex of the lung.
And anchor number 4. The 4 T's for any anterior mediastinal mass, thymoma, teratoma, thyroid, and terrible lymphoma.
So here's a final provocative thought to leave you with. We talked about how pneumonectomy, taking the whole lung, was the old way, and now we do things like sleeve resection, complex reconstruction, which is the new way. The evolution of this surgery seems to be moving from maximal to minimal.
It is. And the future isn't just about smaller incisions, it's about smaller resections. We're realizing that biology is often more important than pure anatomy. With the rise of AI and imaging and robotics in the operating room, I wonder if in 20 years we'll be doing molecular surgery targeting just the cancer cells themselves, leaving the lung structure almost completely intact.
The trauma of thoracic surgery is just shrinking every decade.
It really is. It's an exciting time.
That is a fascinating future to look forward to. For now, your call to action is simple. Open Baily and Love, Chapter 60. Look at those lymph node diagrams. Look at the CT scan of the thymoma. Visualizing it will lock it into your memory forever.
And if the risk assessment math, that split function calculation, flew by a bit too fast, just rewind to Section 2. That logic is truly what keeps patients safe.
Thanks for listening to this deep dive. We'll catch you on the next one.
Breathe easy.